The management of pancreatitis. This is one y'all will definitely see on the wards, so should be helpful. Let's dive right into it. So, a 40-year-old woman is brought to the ER with complaints of abdominal pain. She's pointing to her epigastric area and saying the pain radiates all the way towards her back. Lying down makes the pain worse, and leaning forward makes the pain better. She also has vomited 4 times in the past hour. She has a BMI of 35. You look at her past medical history. She has a history of hyperlipidemia, hypertension, diabetes mellitus type 2. And the meds that she's taking, she's on atorvastatin, metformin, and aspirin. So looking at this case, looking at the history, we have clear signs and symptoms of acute pancreatitis, the epigastric pain that radiates towards the back associated with nausea and vomiting, the pain being ameliorated by leaning forward and made worse by lying back. It's classic. And so we also take a look at her BMI. She has a BMI of 35. You guys will probably remember the mnemonic from first aid: fat, 40, fertile, and female. I'm not sure they're still using that one, but they're describing a demographic that is prone to developing gallstones. And when a patient does come in with acute pancreatitis, that's one thing you want to be thinking of. That is one of the two most common causes of pancreatitis, the other one being alcohol. And so how are we going to work this up? Let's take a look on the next slide. So you want to make the patient NPO, give their digestive system a rest. Let's start them on some fluids. They've been vomiting a lot. And so a bolus or two of fluids, in addition to continuous fluids or just continuous fluids to start off with, lactated ringers, normal saline, that's your choice. Pain meds, you want to get them started on something that can really take care of their pain. Pancreatitis is incredibly painful. So starting off with IV morphine is something that we do at our institution, every 4 to 6 hours as needed. Get them started on some anti-nausea medication. So Zofran, for example, or Phenergan can help here. We want to draw these two important labs, amylase and lipase, with the lipase being the most specific for pancreatitis. And essentially, if these enzymes are elevated, it really points you in the direction of pancreatitis. When the lipase is greater than 3 times the upper limit of normal, that is pretty much confirmation of pancreatitis occurring, in conjunction, obviously, with the symptoms of epigastric pain radiating towards the back. You want to get a lipid panel. One of the etiologies for pancreatitis is hypertriglyceridemia. So you just want to assess if there's anything like that occurring within the lipid panel. In our case, she does have a history of hyperlipidemia, so that wouldn't be beyond the pale, I guess. You want to get an alcohol level for her. Again, one of the 2 most common reasons for pancreatitis is alcohol. And so we can get an ethanol level, a right upper quadrant ultrasound to assess for those gallstones we talked about. We want to get an LDH, and we'll talk about that more on the last slide in terms of how it'll be helpful in prognosticating how this patient does. We want to get a KUB to rule out any other causes of epigastric pain. So does this patient have a duodenal ulcer or gastric ulcer that's perforated? And if that's the case, we should see free air under the diaphragm, for example. Do they have dilated loops of small bowel with no air in the large bowel? That would be indicative of a small bowel obstruction, for example. Although that probably wouldn't be consistent with the physical exam you're seeing in the history. But just to rule out any other causes of epigastric pain that you could see on a plain film. Get an EKG and troponins to rule out any acute coronary syndrome that may be taking place. In an older woman, for example, atypical angina could manifest as like non-specific epigastric pain. And so getting these 2 studies could help you to rule that out. And then, of course, a CBC and a CMP are very important. And we'll talk a little bit more about what to look for on the CBC and CMP on the last slide as it pertains to prognostication, again, for how this patient is going to do. So this is another mnemonic from first aid that I try to keep in my memory when it comes to pancreatitis. I get smashed. And again, really the two most common reasons you're going to find for a patient having acute pancreatitis is going to be ethanol and gallstones, right? It's going to be alcohol-induced pancreatitis or gallstone-induced pancreatitis. But don't forget some of these other ones like trauma. I've never seen pancreatitis secondary to a scorpion sting. That's a really cool fact to know for step one, I guess. Make sure they're vaccinated. Autoimmune pancreatitis, steroids, hypertriglyceridemia. These are some strange ones that you may see on wards rotations. ERCP, right? Have they had a recent ERCP procedure? Maybe they came in with acute cholangitis, had to have a stone removed, and now as they're recovering from their cholangitis or developing epigastric pain, maybe this is iatrogenic induced pancreatitis. And then drugs, sulfa drugs like Bactrim, for example. Do they have a past medical history of HIV? Are they on NRTIs or protease inhibitors? These are suspects for pancreatitis as well, drug-induced pancreatitis. And it's not just limited to these three. There's a whole category of drugs that has some association with pancreatitis. So it's make sure to do a thorough investigation into that when looking through their meds list. So again, we talked about making them NPO, giving them some intravenous fluids, giving them some IV morphine, giving them some IV Zofran, both as needed, discontinuing any potential drugs that could be causing this pancreatitis. And then a general surgery consult may be warranted if on right upper quadrant ultrasound, you see gallstones, you see gallbladder wall inflammation, right? Maybe some cholecystic fluid you're detecting. They need to have an urgent cholecystectomy, and that usually means within the next 72 hours, right? Or if you're seeing common bile duct dilation on your right upper quadrant ultrasound, it may be important to contact the GI department, consult GI, and see if an ERCP is necessary to remove that stone. Another thing too is if after your diagnostic workup is still equivocal, you're not sure, you didn't get that lipase that's greater than 3 times the upper limit of normal, but maybe it's mildly elevated. But this patient is having that epigastric pain that's radiating towards the back. Getting a CT abdomen pelvis is also going to help you. It will clear up any ambiguity there is with the diagnosis. So that may be necessary, but it's not. You only need 2 of the 3 criteria to diagnose pancreatitis. You need an elevated lipase greater than 3 times the upper limit of normal. You need to have the clinical symptoms of epigastric pain radiating towards the back, nausea, vomiting. And then, again, if those 2 things aren't quite clear for you, you can get a CT abdomen pelvis to take a look at the pancreas itself, see if you can see inflammation, maybe fat stranding. So with Ranson's criteria, this helps you to prognosticate how well the patient is going to do. It's based on initial admission labs and then 48-hour labs. And so on admission, you have, is the patient older than 55? Do they have a white blood cell count of greater than 16,000, glucose of greater than 200, an LDH of greater than 350, right? So this is where the LDH is important. And then an AST of 250, or greater than 250. So if they have all that and then, or some of that, and then 48 hours later, they have some of this or all of this, a decrease in their hematocrit greater than 10%, an increase in their BUN greater than 5 milligrams per deciliter. Both of those are indicative of hemoconcentration going on, secondary to some third spacing occurring. Calcium being less than 8 milligrams per deciliter. Maybe some fat saponification is going on as the pancreas is inflamed. The PO2 less than 60. This could be indicative of ARDS occurring, acute respiratory distress syndrome, a base deficit of greater than 4 milligrams per deciliter within 48 hours, and then fluid needs greater than 6 liters within 48 hours. So if you're having, and if you go on MedCalc will actually have this criteria, and you can actually calculate a % risk score for mortality. So there's a way to quantify this, but if you have a lot of these criteria or all of them, the patient's not doing well and they probably need a higher level of care. So the ICU may be adequate for them. But yeah, that's pretty much it when it comes to pancreatitis. Just remember fluids, pain medication, make them NPO, and then watch them improve, hopefully. And that's pretty much it. New answer, MD, bringing you new answers.